Hey, I see some familiar faces and some new faces too, so super glad you guys could join us today. I'm going to go ahead and jump in. I'm sure we'll have some additional people join us, but good afternoon. My name is Haley Bell. I'm a training program manager with Telehealth Rocks, and I get to facilitate today's session. So we're super excited to have you guys here for the sixth session of our new Echo Light training series, supporting the whole child, connecting brain health systems in practice. Next slide, please. So before I jump in and hand it over to our presenters, I do just want to take a second to kind of reground us in what the series is. So we are meeting twice a month, and really the series is meant to build over time. It's grounded in the whole school, whole community, whole child framework, really providing us with a way to think about how systems connect around children with all of the different topics that we cover. We also want to make sure that the sessions are interactive. So each session, including today's, has a case-based approach. So we'll have an example later on that we can all talk through and really just create an environment where we can learn from one another and kind of so that you all have a chance to envision yourselves in the case example as well. The series is also designed to bring multiple disciplines and perspectives. So you'll see today our two speakers bring their own perspective, and we will carry this throughout the rest of the series. And then everything in the series is focused on real world practice and collaboration. So really, really want you guys to be able to walk away and envision what each topic looks like in your day-to-day work and life. Next slide, please. So super excited to get to introduce our two speakers today. First, we have Ryan Smith. Dr. Smith is an associate professor in the Department of Pediatrics at the University of Kansas Medical Center. He serves as the medical director of informatics for the department, as well as a founder and director of the Pillars Medical Complexity Clinic at the University of Kansas Health System. Dr. Smith received his medical degree from the University of Kansas in 2010 and completed categorical residency in peds at the University of Minnesota in 2013. He also secured board certification in clinical informatics by the Practice Pathway in 2017. So super excited to have Ryan join us here today. We're also joined by Deb Cook. Deb is a registered nurse and certified asthma educator with 43 years of nursing experience. She retired from the Kennett Public Schools in Missouri after serving for 29 years as their director of health services. Throughout her career, Deb's been actively involved in school nursing leadership at both state and national levels. She's also served in numerous roles within the Missouri Association of School Nurses, including the president role, as well as being a member of the board of directors for the National Association of School Nurses. Deb also serves as a hub team member for the Show Me Echo asthma program and previously served on the hub team for the Trauma Informed School Echo program. So we're super excited to have both Deb and Ryan join us for today's session. Next slide, please. So just to give you a really quick overview, in our session today, we are going to explore the care, coordination, and resources that support children with medical complexity, and also examine the school nurse's role in collaborating with families, providers, and school staff, really as a way to promote wellness and success. And then for the WIS component that we're covering today, we will be mainly in the health services and a little bit in the education side as well. Next slide, please. All right, so before I hand it over to our presenters, I do just want to quickly review the learning objectives for today's session. So by the end of the session, you should be able to identify the multidisciplinary team involved in the care of children with medical complexity. You'll also become familiar with clinical and administrative resources that are available to children with medical complexity. And then you will be able to describe the school nurse's role as the coordinator of the interdisciplinary team in not only developing, implementing, but also evaluating individualized plans of care for medically complex students. And finally, you'll walk away being able to identify strategies the school nurse can use to collaborate with families, healthcare providers, and school personnel. So with that, we can go ahead and go to the next slide, and I will hand it over to Ryan to get us started.
Thanks so much, and I appreciate the introduction. I'm so happy to be able to share this educational session with Deb. Some of these slides are taken from previous Telehealth Rocks Echo sessions that we had around medical complexity, and some of the slides have our partners cited, Dr. Emily Goodwin with Children's Mercy and Dr. Dana Bakula also with Children's Mercy. So when we think about medical complexity and children with special healthcare needs, we need to kind of start with what defines that population. First of all, it's much greater than I think most people appreciate. About 20% of U.S. children have special healthcare needs, have medical complexity. We can see a definition right there. And the important thing is that there's different components. There can be social complexity, emotional complexity. I think people are very kind of anchored in developmental kind of physical abilities, with cerebral palsy being one of those things that really immediately jumps out to people when they think about medical complexity. But it can take different shapes. I think that's a really important thing to realize. And like when we have patients that have greater complexity, they have more needs, like having a systemic way that we approach problems and understanding that each young person is a little bit different in some of the challenges that they may have. Next slide. This is kind of a visual representation of what was on the last slides, but I think it's a good kind of call out for children with medical complexities, the different domains that we have to really focus in on. So understanding functional limitations and how those affect a child in their daily life, how that affects them getting around and participate in different school activities, their healthcare use, and actual risk for events at school and out in the community. So what types of events have happened in the past, and how can that inform what we're going to do in the future? What is the full breadth of problems that they have or chronic conditions? And then what are those needs that the patient, the young person has in the healthcare setting, the community setting, but then also with us in the school-based setting. So next slide. One of those things that I think gives even our medical students and pediatric residency trainees some pause is the different assistive technology that our patients may leverage to function appropriately. This large blanket of assistive technology. And sometimes it'll be getting to some basic core functions, breathing, circulating, stooling. Sometimes it'll help a child get around. Sometimes it'll help them communicate. I think like for as much as I struggle with tablets in school, having 7-year-old children, like tablets and communication devices have really gone a long way in allowing medical complex, functionally limited children to communicate appropriately. And so there's a breadth of different technology that these children may have. And as we get more familiar with it, as we build partnerships between our like school-based, community-based, and healthcare-based partners, I think we can be a lot less intimidated about some of this technology. Next slide. When we think about like medical interventions, medication administration is one of those that is important to call out. A good portion of the patients that I see will get medications 2, 3, 4 times a day. And so that leaves them at least getting med administrations once or twice each day. And I think the important thing is that there's been a lot of investment in the pharmaceutical industry to support effective means of administration. Realize like some kids can swallow pills and that's an easy thing to do, but understanding like there's other ways to get medicines into the system, especially in emergency situations, things like sublinguals, injectors, nasal sprays. All those are alternative ways to provide medications that can be really helpful in the case of medical emergencies. But there's lots of different ways that we get meds in right now, which wasn't the case, I think, a generation ago. Next slide. So this is I've shown this at most of my presentations of medical complexity. Um, it's a bit dated, but I'll say that it gets to one of those things that I think is so important, which is the incredibly large team that it takes care of to keep a medically complex child with special health care needs thriving and progressing. And so I think there's a few things to call out. You can see the different kind of branch points: school, health, kind of family supports and legal financial things. But the other thing to call out is that like right there in the middle is the patient and the parent, and that's who we are working towards serving. And again, like communicating with them, communicating with each other is the best thing that we can do to kind of move forward outcomes for these children. And so you can see like this is a partial list, and I will say like just doing the healthcare teams for some of my patients, there can be 10, 15 people on that list. And I know that that's only a small fraction. And if we get the full kind of diagram on some of my patients, I'm sure that you're closing in on uh, 50, 60, 100 people that are really invested in an important part of care for these children. So next slide. And this is kind of borrowing from our previous Echo series on medical complexity called Under Run Roof. And I think it's that concept that's really important, is that we are all working together here. And again, like can't stress enough the centrality of parents and caregivers, but understanding that some young people require private duty nursing. School administration, especially when specific accommodations need to be made, is really important. School health personnel, teachers, the healthcare team, social workers, counselors. Like, I apologize for not making an exhaustive list here on this slide, but it's so many different people working together to try to provide wellness, promote care, promote progress for these young people. Next slide. And I guess people can put it in the chat. I'm kind of curious to know how many people have heard of emergency information forms, if they actually seen emergency information forms. These take a few different shapes depending on the clinical care setting, depending on um, who's seeing the child. But the AP, the American Academy of Pediatrics, has a form for children with medical complexity that should be exhaustive for patients with medical complexity, that will provide a list of all the problems that the patient may have, meds, allergies, other kind of extremely critical information, and then a series of kind of if then type scenarios where if the patient has intractable seizures for more than 5 minutes, in which like the patient turns blue, becomes limp, then you do X. If the patient starts to vomit uncontrollably while taking a feed, we stop the feeds, we wait. So this is where like it can be so helpful to understand what's happening in school, hearing that from the patient, the caregiver, from the school team, so that we can kind of get that if and then build out a then to make sure that these things that are common, that kind of routinely happen, don't become a big surprise. Contact information, I think, is really important too. So understanding who's the medical team, who's in charge of what problem, who we contact when a child is having a particular issue. And then there's this concept of a go bag. So all of the core medical equipment that a patient may need in the case of a medical emergency? Do they have their seizure rescue medicines? Do they have their muscle relaxers, their anxiety medicines to calm them down? But the go bag is kind of one of those things. The replacement of a G tube or a Foley plastic catheter to put in a gastrostomy kind of opening in the stomach if uh, a tube falls out. So that go bag should have all the medical equipment, and then the emergency form should have all the content and information that you need to kind of troubleshoot through expected and or like previously occurred issues. Next slide. And so that emergency information form a lot of times will be very exhaustive. That's kind of paired with this other idea of action plans. And I'm sure Deb could give us a lot of discussion about the asthma action plan. That's the one that kind of was first broadly used in clinical practice. And then all these other conditions kind of latched on. I've seen seizure action plans, hypoglycemia and hyperglycemia action plans, constipation action plans. Pulmonary action plan is like if you have someone with a trach or just chronic issues with breathing, how to suction out, how to clear, how to intervene when needed. And these are just some of these other type things that uh, you may have a dedicated action plan outside of emergency information form, that kind of exhaustive form. And again, understanding that like concept for this is where a patient normally is, this is where some of the mild problems that we may encounter, and this is what we do, versus like in real emergencies, this is how we act, this is how we intervene appropriately. Next slide. Katie Beckett, I know when I was um, preparing this lecture, Haley was like, I was a little confused because it just had one name on a slide, and that was by design. So Katie Beckett, I think, is a really important story, and I'm kind of running low on time, so I won't spend a huge amount of time. But Katie Beckett was a child who had some chronic disease that required some very intensive respiratory support. So she was on a vent, on a trach, had a feeding tube, had a lot of needs. And this was in the early 80s, in which there wasn't really a precedent for private duty nursing for patients. There wasn't really a structure to provide durable medical equipment for this more advanced assistive technology. So Katie was someone who spent 2 years just in kind of a long-term hospital, stable, not able to spend time with their family, not able to go to school, not able to be an active member of the community. And so the Reagan administration in the 80s, interestingly, like they interacted with Katie Beckett's parents and made a determination that in certain settings that young people can go home and receive some nursing care, receive appropriate medical technology to support themselves. And that kind of fundamentally changed care for children with medical complexities, where it used to be all of these children lived the entirety of their life in long-term care facilities, nursing homes. And this is what made it possible. And this funding came through Medicaid. And what they found is that providing care in the home, even when nurses are needed, heavy equipment's needed, it's so much less expensive and so much better for these children to go about care that way. So I think Katie Beckett is one of those people to kind of call out and talk about how important it is for appropriately moving care and life forward for these young people. Next slide. So this is like some of the different home care that different patients may get. You can see it's a long list. And again, like we began to mention like the long list of stakeholders like within the school setting and just within the healthcare setting. This is a partial list by general groups. And so again, just demonstrating all the different people that it takes to keep these young people well and progressing and doing great things. Next slide. Again, I'm right at my time, but I think we can answer this in later on. But when we think about like home care financial supports, like private duty nursing and assistive technology is largely guided by waivers, the technology assistance waiver. And so there's a score that happens with medical complexity that dictates your ability to get different care services, different technology. I imagine many of you are familiar with the SBDT. So early intervention services, a pediatrician, we are very focused on development and early visits to get people in and connected when they need support. For financial supports, like and for guaranteed medical insurance, SSI is important for those children with persistent disabilities. And then home health, again, like which could be just intermittent visits or kind of established private duty nursing. Next slide. So I'll pass this on to Deb.
Deb, I think that you're muted. I'm not able to hear you.
I forget that every time. I'm sorry. So, thank you, Dr. Smith, and thanks to Telehealth Rocks for having me involved in this. I am a person who is always excited to share information about school nursing. As she mentioned, I'd been the Director of Health Services for 29 years, and I never intended to stay that long, I promise you, but I loved school nursing and working with kids. Next slide. So I'm going to go through these slides kind of quickly and just the introduction. I'm just going to talk about the importance of supporting students with complex health conditions. And I want to just point out, we talk about complex health conditions, and some of the things I'm talking about today, some of the students, we typically refer to as chronic health conditions. Complex health conditions are usually those that are more involved and require more care, but we do want to think about all students. And they, to a parent, they may consider their child with asthma to be a complex health condition. It all depends on the severity and what's involved. But complex health conditions, chronic health conditions, all can impact the attendance and academic performance and participation. And therefore the overall well-being of the child. It can just impact their whole life. So we really want to take a role of advocacy here to make sure we provide what's needed. So we're going to talk today about the role of the school nurses care coordinator. I noticed there's not many school nurses on the call, and I'm kind of glad because I think it's important for others to learn about what is the role of the school nurse for the child, or what all is involved in the child with complex health conditions. Next slide. So, understanding complex medical conditions, as I said, we're talking about complex and chronic. It can involve any of these. I'm not going to read them for time's sake, but just, take note. There's a lot of things, and there's several things that aren't listed here. Dr. Smith mentioned constipation, and you have encopresis, and there's just so many things. So many children with complex medical conditions end up with other issues, such as constipation, breathing issues. Next slide. And so Dr. Smith also talked about building the school health team. I think it's important to note the school health team may encompass others. You have community partners. So like in my school district, we didn't have a full-time physical therapist or occupational therapist. So we contracted companies to come in or specialists to come in and work with us on that. So the school health team can be very large, as he mentioned, or it can be a small team. And typically, you want to think about the school nurse as being the leader of that team, but not always. Like you have special education directors, sometimes they're in charge of it because the child does fall under SPED with having an IEP or a 504. So it's that we're a team and we all work together. And the school nurse's role may be that of making sure that you think about the communication, and the school nurse's role is there as the advocate to explain what the condition is, what it involves, and also, for example, like making sure they're meeting the needs. And sometimes it would just be as simple as discussing, like sometimes the teacher at the beginning of the year would be getting a complex medical student and she'd just be like, oh, I can't deal with that in my classroom. There's no way I can do this. Like on and on. And then when you start talking to her and educating her and providing resources, she understands it is doable. And typically it ends up that they enjoyed having the student, they learned a lot. It was a challenge, yes, but also it was so rewarding that they were able to help it. So the school nurse's role is building that team and the enthusiasm and reminding everybody why we're there. It's for the kids and helping them. Next slide. So we have to start out of thinking about what are the needs. Reviewing, as they mentioned, the information, emergency information that the parent fills out at enrollment. And when a child has a health concern or a health need, complex medical condition, think about that. Put that card in an additional pile and then think about it. What are the challenges going to be? What are the needs going to be? What is the child's knowledge of their condition? What is the parent's understanding of their condition? And a lot of times that's where we become the educator. The school nurse has to educate the parent about how to help the child and make things better, getting the parental consent and releases. And I think this is, very important to begin with, to make sure you have all of those. And the more we can communicate, the better. And then I mentioned about the health status, the child understanding, the parent understanding. What are the potential barriers to learning? Okay, so if that child has physical therapy so much time and speech therapy, and they've got to be gone every Wednesday for oncology for an infusion appointment, how many things and how much time are they out of the classroom, and how do we work around those barriers? How do we, if the child's riding a bus to school, how do we make sure they have the equipment they need at school and home? How do we make sure that they have a set of books maybe at home and one at school so they're not having to carry them back and forth? And then the emergency concerns. And I love that everybody was interested in the emergency information form because that makes so much sense. Like I think about that being the communication tool between all of us. And it's like, here's our go-to. Like if something's happening, let's go to our emergency information form. And this is where we can also plan from. Next slide. Planning care, coordinate the meetings, parent, teacher, administration. And in my years, I never found a teacher that was excited when I went to them and said, we need to plan a meeting. They all felt like they were meeting out, and I understand because they were. But it's very important to have those meetings, those discussions, have the right people at the table to discuss and figure out what's needed. A lot of times before the IEP meeting happened, I might go and meet with the teacher, meet with the personal aide that was helping the child, might meet with the administrator, the SPED director. I would try to make sure I educated myself on the challenges of that child. Say you have a child with a condition that affects their hearing and they have a hearing aid, and I want to know, okay, who's checking the hearing aid every day to make sure it works correctly? Who's changing the batteries? I mean, there's just so much in that. So the school nurse needs to make sure they gather that information, ask the right questions. I often talk about asking the right questions. And then you have the information when you get to the IEP meeting to discuss this, or the 504 accommodation meeting. Developing emergency plans, and yeah, asthma action plans are a big one. My big thing is about action plans. They are very important. You need emergency action plans, but they need to be doable. They need to be applicable. Like, for example, when I first started in school nursing, I'd come across an asthma action plan that said, if wheezing, give albuterol. If respiratory distress, call 911. Well, that was pretty much all common sense. I want to know exactly what are the steps, like, like if they ride a bus, do they need to sit in the front of the bus so that the bus driver can be aware if they're having any difficulty breathing, or if they have seizures, or where is the albuterol? And like sometimes it would even say give a nebulizer treatment. Well, I'm like, nobody can do a nebulizer treatment on a bus. Like, we got to think about this. So your emergency action plans need to be usable. And that's when you're looking at them, make sure they're doable. Make sure time frames are good and who's going to do what. Like, I think about, if you have a cardiac emergency, who's calling the ambulance? Who's getting a copy of the demographic information to send with the ambulance? Who's going to watch for where the ambulance goes? Those things seem little, but in an emergency, they're big. So it's good to have all the information and practice responses. Your daily management, it may involve the medicines, as Dr. Smith mentioned. Some kids get multiple medications, and I think it's important when you're in those meetings to talk about, how do we keep the time out of class to a minimum? Like, what do we do? So we need to be looking at that and think about, how do we make this better, talking with the provider, because sometimes the providers don't think about the time out of class, and they'll order nebulizer treatments at school, twice a day. And you're thinking, okay, if I can teach this child how to use albuterol inhaler effectively with a spacer, that's only like 5 minutes out of the classroom, where a nebulizer is 20 minutes, all depending on the developmental status of the child, the maturity, and if they're able to do an inhaler. But that's just some of the things that sometimes parents don't stop and think about. Medications. I want to bring this up, and I'm short on time, but I do want to talk about this. A lot of school districts in Missouri, I haven't looked at Kansas, but a lot of school districts in Missouri, their medication policies will say they give medications if it's required by the IEP or 504. Sometimes medications are needed outside of an IEP or 504. For example, and I keep bringing up asthma, but it's just one I work more with, so I have more examples. But say a student is on a controller twice a day, and they keep on having to use a rescue inhaler at school, and you're talking to the child and they missed their controller dose that morning, and you talk with the parent and they're like, oh yeah, we got busy, I forgot it, or I didn't think they needed it. And you find out that, life gets hectic. And I just think, my kids were 8 years apart, and I was challenged. Like, I was challenged in the mornings with getting them to school and getting myself to work, and I think, if a parent is dealing with multiple things, and maybe their shift starts at 7 a.m. and somebody else is getting the kid ready and getting them to school, there's all kinds of things that can happen. Is it a parent's responsibility to make sure they get their medicine? Absolutely. But if the role of the school nurse can be, oh, we give this controller at school every day in the morning, we may be able to, this child's doing better, can stay in their seat and not have to leave for albuterol throughout the day, and avoid the child having difficulty with their asthma because they're getting it regularly. So just keep that in mind. Like, sometimes we have to go to the gray areas. Always follow your district policies and procedures. I'm not asking you not to, but maybe you need to advocate for changing those. And then supplies, especially with like diabetics or some of the children that Dr. Smith was talking about with catheters and tracheostomy tubes and everything. In those meetings, decide who's responsible for having what there. And sometimes it's just good for the school to have some backup supplies. Funding's tough, it's getting tougher, but just think about talking with the parents or with the insurance. And I also think about this. If a child is on Medicaid, then a lot of times they have a case coordinator, a care coordinator person, and you're having trouble getting the equipment you need at school. Talk with the parent, get permission, consent, but talk with that case coordinator and say, hey, we need some backup supplies here at school. Dr. Smith talked about the emergency go bag. Absolutely. You don't know how important that is, even for the child, the diabetic child. Like, in the event that you have to evacuate the building, you have a lockdown, It doesn't have to be that the child has an emergency, but there's an emergency in the building and something happens. Or there is the fact of, I lost my train of thought real quick, sorry. Field trips, thinking about that, and we'll mention that in a minute. But in those meetings, discuss who's responsible for the supplies, and then let's have some backup plans. Take advantage of those MCOs, the managed care organizations, or Medicaid. They have a lot of resources, and sometimes we don't even know all the resources they have until you ask the question. Next slide. So coordination and training, this is big. We want to make sure we coordinate between communicate between all stakeholders, maintain confidentiality while providing safety. And I get a lot of conversations with school nurses about, everybody in the school thinks they have a right to know. Yes, they do. It's very controversial, but to me, the person out on the playground that's monitoring the playground, they need to know which kids, have this condition or that condition. Now, bedwetting, no. The person on the playground doesn't need to know this kid wets the bed at night. But they do need to know if this child's diabetic and they're acting differently than normal, then we need to do something. Some may argue, well, if a child's acting differently than normal, you should alert someone anyway. So, but I just think usually I talk with the parent and say, hey, these are the people I think have a need to know. And so that's when I can say, yes, the playground aide, the monitors, the paraprofessionals, which ones do we want to tell? And then the parent feels involved in the child's decision making and they respect that you're asking the questions. They may say no, and then we deal with it. Also, think about transition planning. A lot of times in March or April, I would talk with building principals and the counselor, SPED director about, okay, this child's going to be moving to this grade and we need to decide where the bathrooms are because they need a private bathroom to do their catheterization, or they're moving to a different building. There's also the staff education and training. Think about when the nurse is going to be out of the building, what happens. That's a different picture in a lot of different schools. And then sharing the relevant information. Next slide. So participation in school activities, I've talked about this a lot. Ensuring inclusion and safety is my big one here. Yes, you want all those things to happen, but the child who is physically disabled, what are they doing in PE class? Don't just have them sitting there watching all the other kids having fun. Talk with the physical therapist for the child. Talk with the parent. Talk with the doctor. What can this child do? And then decide, is it necessary for this child to go actually to the PE class? Does the child want to go down there? What exercises could the child be doing while the other kids are out running around the court? Because I want all kids to feel good about themselves. And this is where I just think it needs communication. And then transportation. You want to make sure you have transportation. Next slide. Monitoring and evaluating, I think sometimes we forget this. We put a plan in place and we think everything's going good and we don't step back and evaluate. I think it's a good idea. Once you implement a plan, then set up a date to reevaluate, to come back together and say, hey, what's going on? A lot of times what I would find in that meeting is there was somebody that thought someone else was doing that task and nobody's doing that. Nobody's in charge of checking the hearing aid, or nobody's in charge of making sure that there's clean catheterization supplies in the bathroom for the child. So think about evaluating how it's working. The big thing is ask the child how things are going. Are they seeing any challenges? Ask the parent, does the child come home and complain about anything? Is everything going good? So the school nurse has a true leadership role. I want to make sure I emphasize that we all are a team, and oftentimes we need to work very closely with the special education department on this part of it. But coordinating, I considered my role to be the one who would talk with the outside medical providers because I could better interpretate that information coming back. And when I was talking with the provider, I was better at explaining what we could do in the school setting with school health, so that they understood that part of it, because sometimes they would think it would be different than it was. They think, oh, you have a school nurse at school. They can do this, this, and this. And it's not that easy because the school nurse may be there for 800 kids. Next slide. I do want to point out using evidence-based practice. I sometimes was considered like that rule follower. I'm a rule follower somewhat, but I believe in gray areas. But I do think I came to love evidence-based practice. I loved when I was talking to someone about advocating for a child, I could say, this is the best practice. This is evidence-based. And I could do that across the board and feel good about that for every child. So I'm just going to end in this with an overview that caring for students with chronic medical conditions involves a variety of important responsibilities. The school nurse does play a central role, but we do it with a team to ensure the student's health. That's the only way it can work, is that we're a team and we work together, we communicate, and the school nurse is there alongside her teammates advocating for the child's academic success, but also their health and their safety. And then it's important to work collaboratively with the families, the healthcare providers. I mean, sometimes I may be talking to 5 different physicians in the offices to coordinate the care for one child when they have complex medical needs. And so the school nurse is there helping to develop and implement plans. And the school nurse should not develop a plan in silo. They should be getting input. If you have a social worker, if you have a community health worker, involve the team, and then always remember about all of the resources that might be there. For the diabetic child, Medicaid in Missouri, some of the MCO plans, the managed care organizations, they offer cooking classes for parents of a diabetic child. I mean, and they'll provide the groceries for the cooking class and do it by Zoom. So think about knowing what your resources are and keeping everybody focused on what's the least restrictive environment for this child to have academic success. It's much easier for the child to stay home and be homeschooled or homebound. But I would also remind providers, homebound instruction, the requirement is 30 minutes a day. I mean, how much learning can happen in 30 minutes a day? Yes, our district will provide a teacher to do 30 minutes of instruction, but if we can have that child in school, then they're going to get more, even if it's a half a day or part of the day. But then they get the socialization and they can feel more like a normal child and set some life goals for themselves and be more positive environment. But we have to make sure that environment is good and safe, so that they can have full participation. So I know I went fast and talked fast. I'm sorry, but I'm a couple of minutes over, so I'm going to turn it back over.
That was great. Thank you so much, Deb. We're going to switch gears now into our case discussion. Ryan will kind of present our case, and then Deb is going to help lead us through kind of some discussion questions. We'd love to have you guys interact with the discussion questions and share kind of your expertise and tips as well as any questions that you have. So feel free to do that either in the chat once we get to that part, or you can also come off mute and share thoughts and questions as well. I will go ahead and hand it over.
Thanks so much. And this is an interesting case. We actually had already covered this case in one of our medically complex echo sessions previously in 2021, and this was in the midst of all these events happening. Fortunately, I have some updates as to what happened in this particular case that I'll kind of give as we kind of present the case and finish the discussion items. But this is a 8-year-old male with a genetic condition called Prader-Willi that had associated cognitive impairment. Had an IEP, had a 504 plan, was in a special education classroom. I think it's important to realize that it was with a number of neurodivergent young people that were somewhat sensory sensitive. He was having these very regular events, up to 8 to 12 per day at school. And none of these events really happened at home or out in the community. This person got a number of different diagnostic studies, had MRIs like EEGs, which is where they put the electrodes on and look for specific brain waves consistent for seizures. And he did that for like an hour, then he did it for like a day. Then I think he had like 2-week-long hospitalizations to look at his brainwaves to see if there's anything kind of consistent with these classic brainwave seizures that typically respond to medicines. And I had kind of promised Haley that I was going to stay away from too much medical terminology, but I think this is one that may be helpful. This concept of epileptiform versus non-epileptiform seizures. And so the previous nomenclature we use with like pseudo seizures and seizures, and pseudo seizures we've moved away from because again, like these seizures are happening. They need to be intervening. We need to do things. And when you add a pseudo like prefix to it, it makes you think that these aren't a thing, that they are actually occurring, and they are. That the important thing is that these non-epileptic forms, these formerly called pseudo seizures, don't typically respond to medicine. And it's important to realize that both the emergency medicine and seizures are managed so that you have what's called prophylactic medicine, daily medicine that just kind of decreases the risk and the duration of seizure events versus abortive medications that kind of rescue a very complicated seizure that's compromising your ability to breathe, that is too long. And this patient had like numerous different medications tried, had all these studies, and what it showed is that these weren't medicine responsive classic seizures. These were very disruptive. We missed about 40 days in one calendar. When you look at the academic calendar, that's a good fraction. I think it was one every 2, one every 3 days we were gone. And you can imagine how disruptive it was in a classroom with a lot of sensory sensitive, neurodivergent children. And I think that's one of those things that created even more stress in the school-based setting, was that this time was so disruptive for everyone else and so stressful for everyone else. So those are some of the details of the case. We can kind of continue on the next slide with the questions.
Okay, thanks, Dr. Smith. And I'm going to kind of facilitate our case discussion. And, there's been several things in the chat, so I'm hoping people will chime in on this also. But what might be your role in crafting a plan to ensure student safety? What do you think is necessary in that role to craft a good plan for the safety?
Like I said before, feel free to either respond in the chat, or if you'd like to come off mute, you can do that as well, whatever you prefer. It's like Angie said, want to take into consideration physical factors to ensure that the child didn't have any injuries during the seizures. I think that's a really great point, Angie. Thank you.
My challenge a lot of times with administrators was they would immediately jump to worried about liability of injuries if the child started seizing and fell and hit their head. So my response was always, okay, let's put a plan in place to protect them from injury. Like Dr. Smith mentioned, this child was having multiple seizures a day. We had a student that was having, several seizures a day. And so we would have them be in class in like a wheelchair type chair with something on the front of it so they couldn't fall out of the chair. But they were able to stay in class and participate. But that way we could be sure they were safe. Um,
Looks like some other ideas in the chat too, making sure that you have the people who kind of first saw the concern or saw the seizures happening, really making sure that they're highly involved in the planning. I know, Deb, you talked a lot about that too, making sure all the right people are at the table.
Right, absolutely. And making sure like the teacher in the classroom knows exactly what to do if something happens, who to call, how to call, what's going to be the quickest response on that. So that's good. The next question is, how might you help manage the disruption or stress of a medical event in your own organization?
Just chime in. I think going back to what you were talking about, getting everyone on the school at the same page. I think I'd really appreciate both your guidance about with the other students in the classroom, how the classroom teacher, the medical team, the school nurse, everyone, can help support those other students in the environment.
Agree. And sometimes we would have a situation where if the child was having multiple events in a class, we even had situations where parents would be concerned because they would say, my child came home saying that they couldn't have algebra class for 15 minutes because the student was having trouble and the class is only 40 minutes long. I don't like this, So we had to come up with a plan, like where a person immediately went to that room and if it was safe, be able to move that person out of the room so the teacher could continue. Um, and also having people trained quickly available so the teacher could continue her job of teaching the other kids.
I like to another example we had in the chat for kind of helping to manage the disruption was kind of maybe like trial runs of the possible event as a really great like learning tool. So maybe seeing like in the event this was to happen, kind of what would the steps be to take and who all would need to be involved. I really like that idea.
There's sometimes like, Dr. Smith talked about pulmonary emergencies and trach emergencies. And sometimes I think it's good that in talking with the parent, like, can we educate a few of the kids in your child's classroom to alert the teacher for certain things they see? Like the teacher's got 30 kids she's, watching, but maybe this child that's their good friend sitting beside them might notice something different before it becomes, a big event for it.
Yeah, I love that you called that out, Deb. We had there was a comment in the chat about that first question too, of the idea of educating and teaching others, maybe about what the signs of seizures are and kind of what steps maybe even they could take, depending on the age, to help the student if they were to see any of those warning signs. So I'm glad that you pointed that out.
And I think it's even more telling if you think about the playground where, a lot more physical activity, a lot more, energy running through. Sometimes the playground monitor might not notice the first signs, but the kid they're playing with may. So yeah, I think educating the kids and doing it in different ways so that you're sure to capture all the different learning styles to ensure every single person really absorbs what is being said and what's needed to be taught, learned.
Right. Thank you, Angie. And I think, when you do those trial runs, I think that's a great idea. And I like for people to practice food allergy emergency response. Like I would walk in a classroom and say, okay, we have a food allergy emergency, and it was a trial run, but the teacher would look at me like, what the heck? And I'm like, we're going to practice who's doing what, who's notifying the office, who's getting the EpiPen, and doing those trial runs. But my point was, and Angie had some good points about the playground stuff. What about the event, the days when the normal people aren't there? Like, what's your backup plan?
And we had a question in the chat too, Deb, regarding if there was an MCO role around resources that may help families kind of in this specific kind of case example. And Ryan, I know you may have some thoughts as well.
Well, one example I could give is that we had a child that had a trach and had to have frequent suctioning. The parent only had one suction machine at home, so her plan was to bring it back and forth every day to the school. And we did not think that was a good plan because what if she forgot or what if she was busy? So we talked with the MCO organization about would you provide this child an additional suction machine at school? And within days we had one. So I think yes, MCOs do. I've been like in the past couple of years working closely with some MCOs, and I'm amazed at what all resources they have. But I've learned as school nurses and schools, we don't know to ask. Like I even find that medical offices don't know. Like a lot of the MCOs in Missouri, I say a lot, the three MCOs in Missouri all provide asthma supplies. They'll provide mattress covers, pillows covers, spacers, nebulizer. There's they provide different asthma supplies, diabetic supplies. I mentioned the cooking classes. And for like children with autism, they'll provide sensory kits for the classroom teacher. So yes, there's a lot of resources there.
Yeah, and I think in general, like it's probably not as relevant to this case due to kind of the medical circumstances, the fact that these aren't necessarily medication or health intervention responsive seizures. But it is important to just call out that again, the MCOs, the managed care organizations that administer Medicaid in Kansas and the majority of the states around our country, they're the primary payer for all medical equipment, private duty nursing, all of this support that young people and some adults with limited functional ability, complex medical conditions. That's where they get that from. And so, again, like they are a good first partner to look at. There's also state programs and non-for-profit charitable entities that can kind of close the gap if certain needs are needed. If you need another suction machine, if there's a special chair that like is needed to appropriately kind of move forward with functional like ambulation or other activities. So there's lots of resources out there. Getting familiar with those in communication with the healthcare team, with the nursing team, those are always really important.
Thank you.
I agree, Dr. Smith. And I noticed in the chat, I love some of the comments and where they're going about keeping in mind about if someone on the team isn't comfortable. Absolutely. I think that is so important. And then offering them a safe sensory space if they feel overwhelmed. And that made me think about, I want to make the point of when I talked about like we're transitioning to the next school year, I would often go talk to the building administrator and say, hey, we have this child that has some mental health issues or autism or whatever the condition was. And I would like for you to think about what teacher would be best for this child next school year. Because we know teachers have different personalities, they have different teaching methods. Some are more restrictive than others. Some can be kind of laid back and not overwhelming to a child, oversensory. So I think it's important for the administrator and the counselor to think about those things about child placement. Does the child need always special placement? No, but just think about who's going to be on the team for that child and what's the best outcome.
Thank you, Deb. Yeah, I appreciate you kind of calling us back to those. And also thank you guys so much for all the interaction in the chat. I think there's been a lot of good ideas. I do think in the interest of time, I know we're coming up on the hour, so I don't think we quite have enough time to run through the last question, but I do just want to kind of encourage you to think through in your own role how you might help a student similar to the one in the case, or even students that you deal with in your day-to-day. So we can go ahead onto the next slide, please.
And
Good.
okay. I think these are takeaway points. I will give a quick summary of the case, even though we're basically end on time. So we had a lot of I had a lot of communication with the teacher, with the school administrators, with the school nurse, with this particular case. We found that there were some triggers to these events, having a device taken away, particular activities tend to make these more common. So we developed a strategy for him to communicate with the device that he had when he was becoming more frustrated. Usually this frustration is what preceded these seizure type events. We looked at some other external things to kind of make these less common. We were able to make them occur less often, but it was still entirely too disruptive. And so we ended up moving the last month and a half to home-based schools, to home-based school program. And when he went back to school the next year, he actually had no events. He's been completely event-free now for about 3 years. and it was an unfortunate situation when it was happening, but this communication, this troubleshooting, this moved things forward for this next year that he had, and realized that it was a complicated case, and all the communication work we did when we were in the midst of it, I think did a great job of preventing it from happening moving forward. So I think that's a good jumping off point for my kind of reflections on taking care of these patients, which is communication, collaboration is key. We're part of a big team. When we do have standard tools to document plans for specific issues, we always tend to do better.
Yes, thank you, Ryan. I know we have some additional key takeaways here. So I know everybody's got some other things to head to. So I think we'll for sure include these in the PowerPoint that you all will get, and then you can access the recording to see the rest of them as well. We want to go ahead and go on to the next slide, please. So we would love to get your feedback on today's session. It's really an opportunity for you to tell us if the training was useful for you, and even share if there's other ways that we can make it more useful for you in the future. So feel free to scan the QR code that's there on the screen. I've also dropped a link in the chat. I know we've had a few people leave and head on to other meetings. So we will send this out in the follow-up email as well. Next slide, please. And then I do just briefly want to highlight our next session. So our session is going to take place on July 8th at 9 a.m. And we're going to focus on the topic of employee wellness and kind of how by supporting staff in schools, you are supporting the whole child as well. So we'd love to have you join us as Melissa Maris and Shelby Nace will kind of talk through this topic and really emphasize the importance of supporting school staff. So I just want to say thank you all so much for joining today. If you have any additional questions or anything, as always, feel free to reach out to us at telehealthrocks@kumc.edu. Thank you guys so much. Hope you have a great rest of your day.